Thank you, chairpersons, and thank you for very kind introduction. At the outset, I am thankful to Dr. Mohan and his organizing team for inviting me to be here. And yesterday, my colleague Dr. Jagat was also here, so which I came to know by you. So I think the chairperson has also made it clear. The paradoxes are, you can say, native. They are have to be agreed, and they are not the controversies. Very true. So what are the points which I am going to discuss in these paradoxes? Something about diagnosis, clinical examination, management, and complications. And let us see that. What is the paradox in diagnosis of diabetes? We all know these standard criteria, the 4 criteria which I mentioned. That is for the diagnosis of diabetes, where the symptoms with a random plasma glucose of more than 200 or a fasting is more than 126 on 2 occasions, because the fasting is a fairly constant in a given individual as it depends upon the hepatic glucose output. So it is the most reproducible value. It is the 2-hour PPG, it is not the 2-hour random. So remember that it is a 2-hour PPG more than 200 milligram per deciliter after the 75 gram of glucose, or hemoglobin A1C should be more than 6.5%. And we have got enough data from our own country. We also published, Dr. Mohan also published, the utility of hemoglobin A1C in diagnosis of type 2 diabetes in our population. And these you require a reconfirmation, because the diabetes is a lifelong label. So before you make it, it has to be reconfirmed. So what is the paradox here? There is a discordance between fasting plasma glucose and hemoglobin A1C. Only in 40% of individuals they both matches, while in rest 60% they do not match. So here the fasting may be more than 126, but the hemoglobin A1C is below 6.5. Or on the contrary, you got a fasting of less than 126 and the hemoglobin A1C is more than 6.5. So you have got a discorrelation, or you have got a disconcordance in fasting and hemoglobin A1C almost in 60% of individuals. This becomes more wider when you talk about the 2-hour PPG, that is post-glucose, and hemoglobin A1C. So here almost 1/3 of the people, they do have a both in concordance, while the rest two are almost one is concordant and other is not concordant. So this is the graphical representation of this, and you can see that this is the data from the Caucasian population and showed this discordance between fasting and PP. One of the reasons for discordance may be the iron deficiency anemia, and or the iron deficiency alone can also contribute. And this data shows that those, because iron deficiency is associated with the low turnover of the RBCs, that's why there is a more time is available to bind with hemoglobin to bind with globin. So hemoglobin A1C is falsely elevated. So that's the reason for that, and this data was more robust in men than in women. You can see that those who had iron deficiency anemia, men with iron deficiency anemia, 75% had a concordance in hemoglobin A1C and fasting plasma glucose, while this was not so strong in women. So this is our data. We published way back in 2009 in JCM, and that showed the value of a 6.5% has got a sensitivity around 65% only. So it is a low sensitivity. Our specificity was 88%. So the possible explanations for the discordance between the two is the recent or explosive onset of diabetes, like as we have in type 1 diabetes. So therefore the hemoglobin A1C is not recommended for making a diagnosis of type 1 diabetes as opposed to type 2. The coexisting anemias, particularly iron deficiency anemia, concurrent hemoglobinopathies, even the minor thalassemias can also contribute to alterations in hemoglobin A1C. And there is another entity called as a slow glycators versus fast glycators. So we as an Asian population have been shown to have a fast glycators. So even at a lower concentration of a glucose, we bind more with a globin. So that's why the hemoglobin A1C is relatively higher. And further, the aging is also associated with less deglycation, because whatever the glucose binds with the globin, it also deglycates, which does not happen with aging. So we published this data from our own Chandigarh, and that showed that the with aging, like the people more than 70, even they had a normal GTT, but they had a higher hemoglobin A1C. So you have to be cautious that using the same hemoglobin A1C parameters for elderly population. Now we come to paradox in clinical examinations. So these are the two phases of insulin resistance. You see on one side there is a marked insulin resistance manifested as severe acanthosis nigricans. So it's almost grade 4, while on the other side you see the lipodystrophy. It's a generalized lipodystrophy as a manifestation of insulin resistance because of the insulin receptor mutation. So you can see that how the insulin resistance is behaving differently. So this is a paradox in clinical examination you can find. Similarly, the Dupuytren contractures you commonly find in clinical setting, the most common cause being the chronic liver disease or other mechanical causes, while the diabetes is also associated with the Dupuytren's contracture, and we have published this entity as a diabetic hand. We have always heard about the diabetic foot, but we have coined the entity as a diabetic hand, and we have published as a different varying manifestations of diabetes in people with type 2 diabetes. Then other paradoxes in clinical examination, even the dorsal spurious pulse may be absent, but still you may have a diabetic foot ulcer may be present. So this is likely to be ischemic ulcer. If the dorsal spurious is present, maybe bounding, and the foot ulcer is present, then the possibilities are Charcot's, neuropathic ulcer, it may be a small vessel disease, it may be infective endarteritis, or it may be Monckeberg medial sclerosis. So finding a bounding pulse with a diabetic foot ulcer is not surprising. Not finding a pulse without diabetic foot ulcer is also not surprising. And even not finding a pulse and not finding a DFU is also not surprising, because the coexisting collaterals are commonly present, one, and you can have a normal aberrations of dorsal spurious artery around in 10% of individuals. So now we come to the therapeutic parts. So the most common, I think the most common discussed question after the availability of the GLP-1 analogs in our country, the weight regained despite continued lifestyle modifications. So even the behavioral modification program, both diet and physical activity are on, still the weight regain is very common phenomena in real world setting. And this is called as a yo-yo phenomenon, where you lose weight followed by the gain. So this usually happens because all homeostatic mechanisms, they become reoperative once you lose weight. And why does this happen? This happens because once the fat is lost from the fat cell, then they become the stressed adipocytes. So adipocytes, because their residential component is basically fat, if they are devoid of fat, then they are more stressed. And a stressed adipocyte produces more adipokines, more retinol binding protein 4, and they elicit a more immune response. That's why they are basically having a more inflammation there. In addition, the lipolysis is reduced. In addition, the energy intake is increased and the energy expenditure. Even once you lose weight, your BMR, as expected, it should go up, but in fact it goes down. So all these mechanisms are again become reoperative to induce the weight. And you can see that there is an increased uptake by the GLUT4, that is in the muscle, and secondly you have got a PL, that is basically fatty acid transporter, they are also more. So all mechanisms after losing weight or to a certain threshold, they become reoperative. So that's a usual phenomena you see in a real world. That's why the attempt of now say understanding or attempt of the availability of the so many GLP-1 analogs, that diabetes should be considered now as, so obesity should be considered now as a chronic disease. Usually we say the victim is the culprit, but it is not. They are not able to lose weight despite of all efforts. So it means that obesity should be considered as a disease rather than as a social phenomenon. The next question comes, there is slightly a paradox, maybe less relevant in the current scenario, but I think it is good for the conceptual understanding. Is weight gain in type 2 diabetes is healthy? The answer everyone will say no, but there is one situation where it is really healthy. So let us see that. This is the topography in patients with, fat topography in patients with type 2 diabetic subjects. So everywhere the fat is more, the visceral fat, the subacute fat is everywhere, muscle, free fatty acids, liver, arterial, and even the pancreatic fat is also more. We already discussed even a 1 gram fat loss from the pancreas can lead to resolution of a disease or diabetes that was shown in a direct study, and that shows that even 1 gram is detrimental for the beta cell dysfunction. So you have got this is the topography in people with diabetes. So you have got a fat everywhere. It's a both subacute as well as visceral fat as well as ectopic fat. All are increased in people with diabetes. And that's why the term, when the new medicines or new drugs which were introduced in the market, particularly when the SGLT2 inhibitor came first, this term came KG-A1C paradox. Initially, we always had a fall in hemoglobin A1C was accompanied by the rise in weight. So that's why they coined a term first time when the SGLT2 inhibitor came and they led to weight loss. So the KG-A1C paradox. This is the weight with most of the anti-diabetic medications. You can see that. So you can see that even with the glimepiride, gliclazide, and pioglitazone is notorious. GLP-1 can lead to a weight loss of 10 to 20 kg. DPP-4 are weight neutral. SGLT2 inhibitor around 2 to 3 kg. And insulin, you gain weight, usually around 4 to 5, except one insulin which has been shown to be associated with no weight gain, that is Levemir. The Levemir is associated with no weight gain, possibly because the Levemir has got a direct effect on the satiety center. That's why the Levemir was associated with no weight gain. And whenever you gain weight, there is a more risk for cardiovascular disease, cardiovascular complications. So average weight gain of the 1.7 kg leads to increase around 7% increase in the risk of heart failure. But there is only one study, proactive, only one factor predicted that the participants would not die. That was the factor was weight gain. So this was with pioglitazone. I don't say that, I don't endorse that you should give pioglitazone, but you see that what it does. The whole topography changed. You can see that the subacute fat is reduced, the visceral fat is reduced, arterial fat is reduced, even the muscle fat, because now the people are talking about sarcopenic obesity. So I think that one has to be a concept, and I will just share with you that the data were presented for the fatty liver disease. Even a fatty liver also contributes to sarcopenia and sarcopenic obesity. We can have a discussion on mechanistic insights into that later. So here you see that the glitazones, they simply reduce or they melt down the fat. Partly it may be redistribution, partly the weight gain may be because of water retention, but certainly if you do the DEXA studies, you will find that both visceral and subacute fat are reduced. This was our data of pioglitazone and metformin on adipokines, and we showed that with the pioglitazone there was no change in leptin, but there was a change in adiponectin rose, while with the metformin the leptin reduced, but there was no increase in adiponectin. Are we using insulin in insulin resistant states? Yes. We all know that the people with type 2 diabetes, they are insulin resistant, and if you do the HOMA-IR and HOMA-beta or HOMA-IR, then you will find that the majority of the people, even with the duration of disease of 5 to 10 years, it exceeds more than 3.5. This cutoff is basically based the data from the Indian population. So what is the rationale of using insulin in insulin resistant state? This, if we understand the dose response curve of the insulin, then we can shift the dose response curve to the right by increasing the doses of insulin. So we are trying to overcome the insulin resistance by increasing the doses of insulin. So the dose response curve is shifted to the right. The next paradox are vasculoprotective anti-diabetic drugs are always cardioprotective. So we have all, because after the 2007, when the rosiglitazone was out because of the CVOT, and after that FDA asked, or rather, it was mandatory to have a cardiovascular outcome trial. So this question was raised from that. All these drugs are vasculoprotective. They improve endothelial function, but whether they are really cardioprotective or not. So let us see these data. The SGLT2 and cardiovascular outcome, there is a 14% reduction in primary endpoint, so the 3-point MACE is reduced. If you see the data from the GLP-1 and, as one more, if you see the heart failure, 33% reduction in that. So it means that SGLT2 has got a protective effect both on vasculature as well as on cardiac myocytes. So I think one has to distinguish between the two, whether it has got an effect on myocytes. So the cardiac functions are, so the ejection fraction and cardiac functions are improved. That's why it is recommended for heart failure with preserved as well as a reduced ejection fraction. In addition, it has got a positive effect even on a vasculature. That's why you had a 14% reduction in 3-point MACE. However, on the contrary, if you see for the GLP-1 receptor agonistic analogs, the liraglutide did not show the benefit. It showed the benefit on a 3-point MACE. That was a 13% risk reduction. But it was not shown on a heart failure. So you can see that the cardioprotective or vasculoprotective may not be the cardioprotective. And same thing has been shown even with semaglutide. The cumulative incidence of MACE is reduced by 20%, but on heart failure, it is insignificant. So I think we have to do a dissection between the two. The cardioprotective versus vasculoprotective are not synonymous. In addition, if we talk about the pioglitazone, it is the vasculoprotective. So you can see that the time to death and other parameters, they all improved with the pioglitazone. But if you see the heart failure was more. So means the pioglitazone, as far as understanding is concerned, it's a more vasculoprotective. And even the previous data showed that it also prevents stent restenosis. But it inhibits the cardiac myocyte function and worsens the heart failure. So what I mean to say that one has to dissect or segregate the effect of vasculoprotective, means coronary vasculature, versus the cardiac myocytes. These are the two different effects manifested by this. This is a summary of the CV benefits with different drugs. The next, I think, has already been answered. I'll just try to edit the mechanistic insights to that. There is a decline in EGFR, yet there is a renoprotection. It's again one of the paradox, but it does not demand that you should stop or you should discontinue the drug. So here you see that there is an initial decline in EGFR, followed by it becomes a stable. And why there is an initial decline in EGFR? It is because of the restoration of the TG, tubuloglomerular feedback. So the restoration of the TG feedback leads to the constriction of the afferent arteriole, so the blood flow to the kidney is reduced, which eventually leads to reduction in intraglomerular hypertension. And that's why the renoprotection there. So initial decline in EGFR is a good sign, and later on it becomes stable. So if you see the rate of decline in EGFR in people with type 2 diabetes is roughly 1 ml per minute per month. Initially maybe 1.2 or 1.4, but eventually it becomes stable. That's why we say that the initial decline in EGFR may not be really related to, but eventually you gain. So this is the restoration of how the TG feedback takes place, and this leads to constriction of the, you can see that this is the constriction of the afferent arteriole which happens, so the intraglomerular hypertension is reduced. And this is mediated by one of the biochemical transmitter, that is adenosine, which is produced by the macular denser cells. So now the last is the worsening of complications with intensive treatment. So you will be surprised that that if you intensively treat, your aim is to reduce the hemoglobin A1C to achieve the target HbA1c, but the diabetic complications worsens. Possibly because of the adaptive mechanisms are operative. Possibly the glucose itself is a vasodilator which maintains the blood flow to the respective organ. But once you reduce the blood glucose, there is a sudden decrease in blood flow to these organs. Particularly this has been shown in the retina and this has also been shown in the kidney. You have got a microaneurysm in the retina. Similarly, you have got a microaneurysm in the kidney as well as in the heart. So let us see that. I just finished that. The intensive glycemic control and there is a worsening of retinopathy. This is well documented, but after 1 year of this usually becomes stable. So initially there is a worsening, and this is again because of the glucose-mediated vasodilatation effect is lost. And secondly, if you treat intensively, there is a more hyperinsulinemia, more IGF-1 generation, and this more IGF-1 generation leads to more angiogenesis, and this further leads to worsening of diabetic retinopathy. In addition, the other complications which worsen with intensive treatment includes macular edema, and remember, if your patient is in pioglitazone, should be taken away. And the treatment of pioglitazone-induced macular edema is not the toracimide, but it is the spironolactone. There is a worsening of retinopathy have also been shown with liraglutide and semaglutide because you have got a rapid decline in glucose. However, it is again becomes stable. There is a worsening of neuropathy has also been shown called as insulin neuritis, and you can have a severe neuropathic pain after the intensive treatment with insulin. And lastly, anti-diabetic drugs used in non-diabetic states. So this is the table, you can see that. So many in non-diabetic states you are using these drugs. This is our data on a NASH. We showed with this is with the pioglitazone. I think we have some discussion on the fibrosis prevention that is basically mostly done by the pioglitazone, not with the GLP-1, not with the SGLT2 inhibitor. They have not been shown, they have got a more effect on steatohepatitis. And this is our data on the metformin. Even the SGPT levels are returned back to normal. So to conclude, the paradoxes in diabetes are encountered in day-to-day clinical practice and even on physical examination and in management. But I think if they are understood conceptually, I think that gives a better understanding of the subject. And physicians should be aware of these oddities to avoid clinical errors. Thank you for your patience hearing.